Hi.
Hello.
Good evening, everyone. Welcome, Dr. Regina, to chair our presentation, and cases presented by Dr. Anu Phillips. I think we can wait for some more time. 5 minutes we can wait. I think so. So many have 12 have joined. Okay, can we wait, Regina?
It's okay, fine.
So VSR told
sir,
he will join. So sir,
yeah, he's there, no? Sir
sir,
is there.
sir.
Good evening. Good evening.
Sir,
Good
good
evening.
evening.
Good evening.
Okay. Sir, can we wait for 5 minutes?
5 minutes wait. Yeah. I think only a few have joined. No, 5 minutes wait. Yeah.
Okay, sir. So as I didn't see you, sir.
Okay. We can start now, Elizabeth. 7:33.
സ്റ്റാർട്ട് ചെയ്യാം. നമ്മള് വെയിറ്റ് ചെയ്തപ്പോഴും ഫാക്കൽറ്റിയെ ജോയിൻ ചെയ്യുന്നുണ്ട്. PGs ജോയിൻ ചെയ്യുന്ന കാണുന്നില്ല. സ്മിത ജോയിൻ ചെയ്തു. സ്മിത ജോയിൻ ചെയ്തു.
Good evening, sir.
35 വരെ ഒന്ന് വെയിറ്റ് ചെയ്യാം, സർ.
ഒരു 1-2 മിനിറ്റ് വെയിറ്റ് ചെയ്യാം.
Good evening, sir.
Good evening.
Good evening, all other participants.
സ്മിതയും JP ഒക്കെ കറക്റ്റായിട്ട് ജോയിൻ ചെയ്യും.
Good evening, madam. Good evening, sir.
Good evening.
Good evening.
So, Dr. Anu, you are in which year?
Madam, I am in 3rd year now, final year PG.
Final year PG. Okay, fine.
Just started 30th because you're not going to the exam now, no?
No,
Not
sir.
going to the exam now.
No, just started 3rd year.
The final years are going for the exam this week, no?
Yes, sir.
So now can we start? Sir?
Elizabeth, Guru and Shishya, you can introduce and we can start.
Okay. Good evening, all. Good evening, Dr. VS sir, and other faculties, and good evening, and I welcome Dr. Regina as our chairperson for the case discussion, and I welcome Dr. Anu Philip, PG from RIO, to present the case.
Good evening, respected sirs and madams, and everyone present here. I am presenting the case of a 24-year-old male who hails from Adur, a polytechnic student. Presently complaint, blurring of vision in the right eye for 1 month and floaters in the right eye for 1 month. History of present-day complaints. Patient was apparently normal 1 month back when he noticed a sudden onset blurring of vision in the right eye. It was non-progressive in nature. Patient could see distant objects but easily. He also had eye strain while reading, and it was associated with occasional flashes and floaters. And there is no history of redness, pain, or headache, no history of trauma, no history of exposure to pets, no history of ocular surgeries, no history of fever, cough, night sweats, blood in sputum, no history of back pain or joint pain, no history of genital ulcer, oral ulcer, diarrhea, blood in urine and stool, no history of loss of weight or appetite, no history of tinnitus or hearing deficit, no history of any long-term systemic or topical medication, no history of similar complaints in the left eye. Patient consulted at a nearby hospital and was referred to RIO. Past history. There is no history of similar complaints in the past. No history of diabetes mellitus, hypertension, bronchial asthma. No history of past ocular surgeries. No history of contact with known cases of tuberculosis. No history of long-term topical or systemic medication. Personal history, mixed diet, bowel and bladder normal, sleep and appetite normal, no addictions. General examination, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. Skin normal, no skin lesions, depigmented areas or skin rashes. Hair normal, no alopecia or poliosis. Nails normal, no pitting of nails. Pulse rate was 77 beats per minute, regular in rhythm. Condition of the vessel wall was normal. All peripheral pulses felt bilaterally, appear normal. Bilateral carotid pulses appear normal. BP 130-80 millimeters of mercury in the right upper arm in sitting position. Respiratory rate 18 counts per minute. Afebrile. Systemic examination. CVS S1, S2 heard, no murmurs. Respiratory system, normal vesicular breath sounds heard bilaterally. END, Rene's test or air conduction more than bone conduction bilaterally. Weber's test, no lateralization. GIT, no oral ulcer, per abdomen, soft, non-tender, no organomegaly. Genitourinary tract, no genital ulcer, urethral discharge or hematuria. Musculoskeletal system, no evidence of joint swelling or deformity, normal gait. Skull and spine normal. CNS, higher mental functions within normal limits. Cranial nerves normal. No evidence of extrapyramidal signs or meningismus. Peripheral nerves normal. Coming to ocular examination, head posture was normal. No ptosis, proptosis, lag of thalamus. Eyes orthophoric. EOM, versions and ductions full in all directions in both eyes. Convergence normal. Pressing the right eye first. Visual acuity 6-9. Not further improving in glass, not further improving in pinhole. Near vision N8, not further improving in glass. Retinoscopy at 2/3 meters with scopic plus. In the horizontal 90 degrees it was +2 diopters, and in 180 degrees it was +2 diopters. Color vision on Ishihara chart was normal. Field of vision by confrontation was normal. Orbital margins normal. Eyebrows normal. No medrosis, scoliosis. Lids and adnexs are normal. No vesicles, rash, blepharitis or poliosis. No evidence of lacrimal gland swelling. Conjunctiva, no conjunctival congestion. Circumcorneal congestion, no evidence of conjunctival granuloma. No evidence of perineal vitiligo. Sclera normal, no evidence of thinning, scleral nodules, dilated episcleral vessels. Cornea clear, normal size, shape, transparency. No keratic precipitates, corneal sensation normal. Anterior chamber, VH grade 3, no cells or flare, no hypopyon or hyphema. Iris, normal color and pattern, no iris atrophy, neovascularization, heterochromia, iris nodules or sphincter tear. Pupil, 3 mm round, central, direct and consensual light reflex was this. And there was no evidence of any posterior synechia. Lens was clear, and anterior vitreous phase showed 1 plus cell. The slit lamp diagram showing the right eye. Distant direct ophthalmoscopy, red glow was present. Slit lamp biomicroscopy with 90 Media slightly hazy due to vitreous floaters. Snowballs present inferiorly. Disc and vessel C. Normal size disc. Disc has well defined margins. There is no blurring or hyperemia. Vertical cup-disc ratio of 0.3. NRR even and pink. Vessels except the infratemporal quadrant showed an AV ratio of 2:3. Infratemporal quadrant vessels were obscured due to hemorrhages. Perivenular sheathing of the veins in the infratemporal artery starting from one disc diameter below the disc and also its tributaries up to periphery, suggestive of periphlebitis. Multiple superficial flame-shaped reddish lesions with indistinct borders along the infratemporal artery extending from one disc diameter below the disc till periphery, suggestive of flame-shaped hemorrhages. Multiple waxy yellow lesions with distinct margins present just inferior to fovea, extending along the infratemporal artery, suggestive of hard exudates. Yellowish fluffy lesion with indistinct margins, one disc diameter inferior and temporal to disc, and a 3 disc diameters temporal to the disc superior and inferior to the temporal market are suggestive of cotton wool spots. Retinal thickening of about 2.5 disc diameters horizontally and 2 disc diameters vertically, about 1.5 disc diameters temporal to the disc, noted, suggestive of macular edema. No evidence of retinitis, choroiditis, or neovascularization elsewhere. This is a fundus diagram showing the findings in the right eye. Fundus photo of findings in the right eye. IOP with 80 at 11 AM in the right eye is 11 millimeters of mercury, and gonioscopy with Goldman 2-mirror lens by Schaeffer's lady. There was non-occludable angles in all non-occludable angles, and there was no evidence of peripheral anterior synechia or neovascularization of angles. Coming to the left eye, visual acuity was 6.6 and near vision was N6. Retinoscopy at 2/3 meter with tropicamide plus. In 90 degree it is +2 diopters, and in 180 degree it is +2 diopters. Color vision on Ishihara chart is normal. Field of vision by confrontation test is normal. Orbital margins normal. Eyebrows normal, no medrosis, scoliosis. Lid and adnexa normal, no vesicle, rash, blepharitis or scoliosis. No evidence of lacrimal gland swelling. Conjunctiva, no conjunctival congestion, circumcorneal congestion. No evidence of conjunctival granuloma. No evidence of perilumbal vitiligo. Sclera normal, no evidence of thinning, scleral nodules or dilated episcleral vessels. Left eye, cornea was clear. Normal
What were the positive findings, Anu?
In the right eye, the visual acuity was 6.9, not further improving in
Oh.
hospital.
Right eye we finished, right?
Left eye,
Left
madam,
eye.
in the fundus, we have perivenular sheathing in the supratemporal arcade, 5 disc diameter away from the disc, and infranasal arcade, 1 disc diameter away from the disc, suggestive of periphlebitis. This is the fundus diagram showing the findings in the left eye. Summary: 22-year-old male presented with complaints of sudden onset, painless blurring of vision in the right eye 1 month back. It was associated with floaters and occasional flashes. No significant past or personal history. General examination and systemic examination were within normal limits. On ocular examination, vision in the right eye was 6.9, and the near vision was ended, not improving in glass. Anterior segment was within normal limits. Anterior vitreous phase 1 plus cells. Fundus red glow was present, and media was hazy due to vitreous floaters. Snowball was present inferiorly. Disc was normal. Vessel except the infratemporal quadrant showed AV ratio of 2:3. Infratemporal vessels were obscured by the retinal hemorrhages. Infratemporal arcade showed features suggestive of periphlebitis, flame-shaped hemorrhages, hard exudates and cotton wool spots. Macular edema was present. Left eye visual acuity was 6.6 and anterior segment was within normal limits. Fundus red glow was present and features suggestive of periphlebitis in the supratemporal and infratemporal arcade. Diagnosis.
Okay,
Frozen
okay. Please rest. Okay. So the patient had predominantly defective vision with the floaters in the right eye for
Right.
1 month mutation.
Right.
So when a patient says about floaters, what are the other leading questions you will ask?
Whether it was constant in nature or more during evening or early morning.
What is the importance?
Early morning, the floaters can be suggestive of sorry.
Okay, tell me what you
Whether
think.
Whether if it is more in the evening,
Yeah.
it can be due to vitritis.
Okay. Or else? So when it is floaters, first thing you ask is whether it is sudden onset, okay, or slowly increasing in type. Okay. And the second thing is about the size of the floaters. You have to ask size and shape. How is the floater? Okay. Whether it is like as in PVD, whether it is a cobweb, large floaters or anything, or it's like a fine floaters. That always gives you a clue. Okay. If it is a large floaters, you can either think whether it is in vitreous hemorrhage or any vitreous opacities. Okay. And vitritis floaters, how is it usually? Usually it is a fine floaters basically, and it slowly increases with time. Okay.
Okay.
And this diurnal, it's not actually diurnal variation. What you say morning, it is more morning, it is more just because the patient gets up from a lying position. Okay, so this variation of floaters in the morning and the evening happens usually when it is due to a vitreous hemorrhage.
Okay.
Okay, it is not that the vitritis increases in the evening. Okay, so whatever the vitreous opacities or anything which gets settled onto the posterior fold when the patient is in the lying down position, and when the patient gets up in the morning, maybe he or she may appreciate more floaters. Okay.
Okay.
And the next associated symptom whenever patient complains of floaters, next thing you ask is about?
Defective vision, madam.
Okay. So floater associated with defective vision. What are the possibilities?
It can be due to vitreous hemorrhage. It can be due to vitritis, or it can be due to possibility of macular edema.
Okay.
Okay. We can also ask about associated flashes to know any association with retinal detachment.
Okay. So what is flashes?
Flashes are irritations on the RPE, which causes even in the absence of normal visual light, the patient can perceive visual stimulation.
Okay. So this flashes, no, does it only indicate a retinal detachment? What are the other possibilities in which you can get a flashes?
It can be due to irritations of the RPE cells.
Okay.
As in case of
Irritation.
an inflammation.
Situations.
As in case of an
They are
inflammation.
getting irritated, no? What are the situations?
In case of an inflammation, inflammatory pathology in the retina, and autoimmune causes resulting in flashes.
No, you have to say what is happening in the retina. Either a break, either a detachment, any sudden increase in the fluid collection, any traction. Okay, these are the causes for flashes. Break, detachment, sudden increase in the edema, macular edema, even CSR sometimes in the initial phase, very rarely. And in the early phase of PVD, that may cause a traction in the peripapillary retina. Okay, or as the PVD get induced, it can get a small traction as it get induced. So any kind of retinal traction can cause flashes. So does this patient have flashes?
Patient has flashes occasionally.
Occasionally.
Mild flashes now and then, not having any constant pattern.
Mm-hmm. So when a patient says flashes, what is a small extra thing that you will ask? One, whether it is changing with your head position or movement. Okay. So if it is associated with a break or an early RD or PVD, sometimes the flashes may increase with your movement. That is one thing. And the second thing you have to ask is flashes, whether it came along with the floaters before it, like that. Okay. So from your history, what do you think?
It can be due to a vitreous hemorrhage, or it can be due to a vitritis or posterior uveitis,
Okay.
or a vein occlusion, or a retinal vein occlusion resulting in defective vision, flashes, and floaters.
Oh. Now come to your clinical examination. What is the positive finding?
In the right eye, there is defective vision of 6/9, and the near vision is also affected with N8. And
what are the anterior segment finding that you can expect in case of a posterior uveitis?
in anterior segment, in the cornea, we can look for KPs, keratic precipitates.
Okay.
And in the anterior chamber, we can look for cells or flare. And we can look for any hypopyon or hyphema.
Okay.
Then in the angles, we can look for peripheral anterior synechiae or any trabecular measure of nodules. And when it comes to iris, we can look for iris atrophy, iris nodules. Then we can look for
neovascularization.
neovascularization.
Okay. Then
In the pupil, we can look for posterior synechiae, and in lens, we can look for posterior subcapsular cataract.
is RAPD important in this case?
If there is involvement of optic nerve, if RPD would be present.
Okay. So what are the small possibilities in a vasculitis where the optic nerve can be involved? If you say some DDs.
Optic nerve involvement is seen in case of
SLE.
SLE, toxoplasmosis. Then sarcoidosis, tuberculosis can be involved.
Okay.
Then
so anything vascular which can affect the optic nerve head, especially the circulation of the optic nerve head, can produce a RAPD. Sometimes if it is in vasculitis, some associated optic neuritis can happen. Okay. Especially what you call Irvan syndrome and all. Sometimes the optic neuritis or neuroretinitis can be associated with vasculitis. Okay. So RAPD can give you a clue. Or any other vascular disease like small vessel vasculitis, like SLE, vaginous and all, which can cause a retinal vasculitis along with the optic nerve head vasculitis, which can cause an AIO in life picture. Okay, so in both these cases, if the optic nerve head is affected, sometimes RAPD can be there. So, okay, then next. So put your retina picture. Yeah, fine. So what is this chart called?
Amsler's chart, madam.
Hmm? What?
Amsler's chart, madam.
Amsler chart. What is Amsler chart?
Amsler.
Amsler?
Amsler Du Bois chart, madam.
Yeah, Amsler Du Bois chart. Okay. So where should the disk come in an Amsler Du Bois chart?
Temporal to the disc, temporal to the fovea, madam.
Then I will ask where should the fovea comes.
Sorry, nasal to the fovea, madam.
Hmm?
Nasal
So
to the fovea.
where is the fovea? Where is the fovea?
At the center, madam.
Fovea is at the center. And disc?
2 diameter away from the fovea.
What is the size of the disc then?
1.5 millimeter, madam.
Okay. So what are the changes you expect in optic nerve or NH in vasculitis?
Optic nerve, we can expect optic disc, disc edema, optic disc hemorrhages. We can also expect optic disc granuloma. Then optic.
Which is the most common condition which cause an optic disc granuloma?
Sarcoidosis, madam.
Yes, sarcoidosis. Okay.
And also tuberculosis can also be associated.
Tuberculosis can, but most common is sarcoidosis. Okay. And this disc, no, where is it? So what is your thinking after seeing this fundus?
In this fundus, we can see infratemporal arcade being involved with periphlebitis. A yellowish white sheathing of the vessel can be seen, suggestive of periphlebitis, and also retinal hemorrhages can be seen, which can be suggestive of an occlusive retinal vasculitis.
Okay.
And there is involvement of the macula, suggestive of macular edema, and there is also snowballs present inferiorly in the vitreous, suggestive intermediate uveitis.
So basically, it is an infratemporal occlusive phlebitis with superficial hemorrhages and macular edema. Okay. So what are your DDs?
My differential diagnosis is Eales disease.
Okay. What are the points in favor of an Eales?
He's considering his age. He's 24 years old, young age, and there is a occlusive periphlebitis.
Okay.
Which can be suggestive of Eales disease.
Mm.
And in Eales, there is more involvement of the vessels in the mid periphery.
Okay. What is the cause for Eales?
It has an association with tuberculous hypersensitivity reaction to tuberculous antigen, but mostly it can be idiopathic also.
So one, it can be Eales disease. And then say, what is your second DD?
Tuberculosis.
Tuberculosis, plain tuberculosis. Okay.
Ocular tuberculosis.
Okay. So
Here,
Anything?
in his he's in a young age,
Hmm.
and there is we are endemic to tuberculosis,
Okay.
and also tuberculosis is known to cause periphlebitis, more involvement retinal vasculitis, mostly involving the veins, and is known to cause occlusive periphlebitis.
Okay.
And also intermediate uveitis can also be seen in case of tuberculosis.
Next.
Next it is sarcoidosis.
Hmm.
In sarcoidosis has his age correlates with sarcoidosis, and also the patient is having predominantly periphlebitis,
Okay.
which can contribute to the diagnosis of sarcoidosis, and also patient is having intermediate uveitis.
So all your points are basically tuberculosis, sarcoidosis, eels, like that you are thinking. Hello?
Hello, madam.
Hello.
I think
Can you
those who are
please
not
mute?
speaking can actually mute their mics actually.
Excuse me, can you all please mute your mic? There are few people, 3 or 4 people who haven't muted their mic. Can you please mute your mic? Okay, we can continue. Anu?
Yes, madam.
Continue, please.
Okay. So come go to the differentials, your differentials.
Eels disease, tuberculosis, sarcoidosis.
That's it. Yeah. Okay. So if I say it can be syphilis, how will you what are your any positive findings? How will you contradict if I say it as syphilis?
Most of all, syphilis is not that commonly present nowadays because of active antibiotic therapy. Also, this patient in syphilis there is more of arterial and venous involvement, and there is no anterior segment findings suggestive of syphilis. And
among all these things that we have discussed, which has got more anterior segment findings?
sarcoidosis and tuberculosis.
Yeah, sarcoidosis has got more anterior segment findings. Okay. And what is the usual fundus picture of a syphilis, and what will be the history?
History in syphilis there will be oral ulcer, genital ulcer, maculopapular rash on palms and soles, and in anterior segment there can be a circumcorneal congestion, and it can be non-granulomatous or granulomatous, and in iris there can be roseolae, which are dilated vessels present on the iris, and also iris pearls, iris crystals can be there.
Usually it is a little more acute in onset with more defective vision, young males. Okay, and more like a necrotizing kind of appearance will be there for the syphilis. And you can see multiple isolated retinitis patches also along with the vasculitis in syphilis. Okay. Now what you will do with this patient?
We will go for systemic investigations. It can include complete blood count. We will look for any total elevation in total count, lymphocytosis especially, and also we look for ESR, and then we can do urine routine to find any hematuria or any infectious causes in the urine.
Okay.
Then we can do other routine investigations for management like RFT and LFT. And special investigations, we can do MANDO, chest X-ray, and if required, CT test can be taken. Then we can do serum AC and serum
How much
calcium
percentage of the ocular or extrapulmonary tuberculosis you can get a chest finding?
I'm not sure, madam.
It's almost less than 20%. Okay. So anyway, we will evaluate for chest tuberculosis, but it doesn't rule out anything. Okay. If the chest X-ray or CT is normal. But it will help you to get some other findings. What are the CT findings that can happen? Like a sarcoidosis, perihilar lymphadenopathy, fibrotic changes, perihilar lymphadenopathy, all these things you can pick up if you do a CT. Okay,
Then for sarcoidosis, we can do serum AC and serum calcium. And
Yes.
we can do viral markers to rule out immunocompromised state like HIV, HPCG, anti-HCV. And to look for syphilis, we can do VDRL and TPHA. And then to look for toxoplasmosis, toxo-IgG and IgM.
What is the full form of VDRL?
Venereal diseases.
What is the full form of VDRL? Venereal Disease Research Laboratory. Okay. What is TPHA?
Treponema pallidum hemagglutination assay.
Absorption. Okay, fine.
Then for toxoplasmosis, we can do toxo-IgG and IgM.
Do you suspect toxoplasma in this case?
No, madam.
What are the typical findings of toxoplasmosis?
It is usually a solitary retinitis patch, and it can be acute in presentation, and it is associated with more of vitritis. And in posterior, we can see a solitary retinitis patch associated with a heat scar usually.
So toxo usually presents with the retinochoroiditis basically and associated vasculitis. Retinochoroiditis and the adjacent vasculitis can be seen in toxoplasmosis. That is the usual finding, and the vitritis part will be more. Okay. Then
these are the specific investigation, and we can do ocular investigations.
anything positive in this patient?
This patient had MANDO positivity of 14 mm.
Okay.
And serum AC was also high.
Okay. Is serum AC a specific test?
It is sensitive, madam, but not specific.
So if the patient has got TB positive and serum ACE, whether the serum ACE does have any significance?
In sarcoidosis investigation, that is in the classification of International Workshop on Ocular Sarcoidosis, the lab investigation, if it is serum AC is high, it has a contributing
Yeah, this only have a contributory finding because serum ACE can be elevated in multiple diseases. Even tuberculosis can have a elevated serum ACE. Tuberculosis, sarcoidosis, then other infectious diseases like histoplasmosis. So many diseases can have a raised serum ACE. So unless other findings are positive, we cannot make a diagnosis of sarcoidosis with serum ACE alone. Okay.
Okay.
Then?
Chest X-ray was negative. There was no findings in chest X-ray. And so after sending respiratory medicine consultation, the patient was taken CT test also. And
Okay.
also, it was also within normal limits. And sputum CB9 was also negative.
Okay.
So after the consultation, the probability of tuberculosis was considered to be less.
Okay. If the CT test and this is negative, can we say it is not tuberculosis? So what is the any other specific test whether you can say?
We can do quantiferon TB gold assay.
Okay. Then?
Confirmation.
Mm.
Then we can do PCR from aqueous and vitreous fluid.
So PCR from where you will take?
Aqueous and vitreous, madam.
Both you will take.
I first will look for PCR and aqueous. Then, if not conclusive, we can go for a vitreous tap.
Yeah,
and
first always we can take from the AC because it is less invasive and the complications are less. And PCR just needs some sample protein material. So you can always take a AC tap before going for a vitreous tap. But the material will be more in the vitreous tap. Okay. Then? Then you finished your investigation?
Ocular investigation, we can go for OCT. OCT of the macula to see any macular involvement. Then we can do fundus fluorescent angiography. Also, fundus fluorescent angiography to know the involvement of the retinal vessel, especially in this case. And then ICG can be taken to look for any choroidal involvement. Then B scan can be taken to look for vitritis or.
Okay. So what are the findings you are looking in the FA of this patient?
In FA, we see if there is any due to a periphlebitis, there can be a late venous phase hyperfluorescence can be seen, and then you can look for neovascularization and capillary non-perfusion areas. Then we look for the involvement of the macula. And we can see if there is any optic disc edema also.
Optic disc edema. So basically, if somebody asks about the FFA findings, no, you start with the choroidal phase. Okay. So, okay, do you expect anything in the choroidal phase?
If there is any choroiditis involvement, then we will get choroiditis test. But this in case of any choroidal granuloma and all, we can get a choroidal involvement. But then in this case, it is more of a periphlebitis.
No, basically in the choroid, you have to look for whether there is any focal choroidal hypofluorescent area in the early phase. That can either indicate a granuloma area. Okay. And the proper thing comes from the arterial phase. The first thing you look is a disc. Disc early phase, if it is hyperfluorescent, it is an NBD. Okay. Then you look about the arteries, whether there is any arteritis is there or not. Any arterial occlusion is there or not. Okay.
Okay.
Second, you like about the next comes the venous phase. In the venous phase, you say about the leaking and the staining of the vessels. Okay. Then you look in the periphery, whether there is any capillary non-perfusion areas in the periphery, whether it is significant, how much area you have to mark. Okay. Then whether there is any neovascularization, peripheral neovascularization. Okay, these are the things you look in the FFA. So this patient, what are the FFA findings? And the late phase, if the disc is hyperfluorescent, what does that mean? Early phase, if the disc shows hyperfluorescence, that is NBD. The late phase, it shows, it is usually either staining, okay, staining or a leak. What causes the disc staining or leak in a posterior uveitis?
Especially, it is more commonly disc edema can be seen in VKS syndrome. And
basically the inflammatory edema of the disc. Okay.
okay.
Okay. Okay, now you have done the FFA. What is this patient's FFA finding?
In early venous phase, there is blocked fluorescence in the infratemporal quadrant, and vein in the inferior artery show delayed filling. And in late phase, there is hyperintensity and tortuosity of the veins in the infratemporal arteries, with increasing intensity, suggestive leakage due to periflavitis.
Okay.
And tortuous and hyperintense veins are seen crossing the median raphe. It can be suggestive of new collaterals or any new vessels.
It's a collateral formation. Okay. So no CNP areas in the periphery.
Due to hemorrhage, the periphery cannot be visualized, and it had blocked fluorescence.
Okay. How will you identify whether it is a blocked fluorescence or it is a CNP area?
In CNP, there is segmentally there will be hyperfluorescence can be seen, but in blocked, all the vessels will be obscured.
Okay.
And in CNP areas, vessels can be seen.
Vessels can be seen.
Vessels can be in between segmental areas. We can see CNP areas.
So basically, blocked fluorescence, where is the block? What is the level of this block? That we have to see. Okay. If it is a preretinal hemorrhage due to NVE bleed, you cannot see any vessels. But if it is a superficial bleed, sometimes you can see the superficial plexus of veins, superficial vessels you will be able to see. Okay. So that blocked fluorescence will be very dark and well defined. It may obscure your blood vessels. And it doesn't have any particular distribution or anything. Okay. And the CNP areas, those are usually in the periphery, bed-shaped area between the vessels. Okay. So that is. So this patient, does he have a CNP area?
In the present FFA, after follow-up, the patient was shown to have CNP areas. This is the follow-up FFA of the patient, and we can see CNP areas in the infratemporal and temporal areas.
Okay. So what is the role of FFA in the early phase of vasculitis? Why did you do an FFA early before starting this treatment in this patient?
To identify vessel involvement, whether it is more of venous or arterial involvement.
That we can see clinically, right?
Yes, ma'am. And to see
So
if there is
usually,
choroidal.
usually in the first clinical interact, if you ask for an FFA, it is when you have a doubt whether it is an active vasculitis or a old vasculitis, which has got some sclerotic element or a sheathed vessel. So you want to see whether it is active or not. That activity, whether if it needs any treatment or no treatment, you have to decide upon your FFA. Okay.
Okay.
So, or else if you want to, if you are in a confusion whether it is a vasculitis occlusion or it's like a otherwise retinal vascular occlusion, you want to differentiate. Where you can just see a sclerosed vessel in a young patient. You don't know whether it is a old vasculitis or it is a otherwise vein occlusion. Okay, so that is the situation where you usually ask for a early FFA. Okay, now that it is a active vasculitis, what is your next plan of treatment?
We can consider giving steroids.
Okay.
Since this is a posterior involvement, we can plan for giving a systemic steroid.
Okay.
And we can also have other methods of steroid like periocular and intraocular steroid administration is also there.
For vasculitis. For vasculitis,
intermediate
for the vasculitis, the preferred is systemic steroids. Okay. Then after
systemic steroids, if the patient needs prolonged steroid therapy, we can consider immunosuppressants.
Okay. What are the situations in which the vasculitis may be resistant or may be less responsive to a systemic steroids?
Mostly in cases of mostly indicated in cases of Behçet's disease leakage, sympathetic ophthalmia, we go for immunosuppressants.
Yeah, I asked vasculitis. Behçet's is the right answer. Okay. So
when there
what is the okay.
Severe systemic involvement is expected, we can definitely go for a immunosuppressive therapy.
What is the peculiar appearance of a Behçet's vasculitis?
Behçet's vasculitis, there can be both periflavitis and periarteritis.
Okay.
And
Behçet's is a very acute appearance. Okay, patient will be usually very sick with some systemic factors, congenital ulcer, or oral ulcers, skin eruptions. And the vasculitis is usually also patient will have can have vitritis, and the chances of optic neuritis is also high in Behçet's. Okay, and the peculiar FFA pattern that is seen in Behçet's is a fern pattern. Okay, that's a beautiful fern pattern. You can see where all the blood vessels are involved. So in Behçet's, most of the time, the patient may have to start with a high dose systemic steroid, IV, MP, or DEXA. Later on, patient may sometimes lead long-term immunosuppression. Okay. Okay, so for this patient, you gave systemic steroids, right?
yes,
Then, what did you do?
We gave systemic steroid. The patient improved on systemic steroid. Macular edema has resolved. But since the patient was considered needed long-term steroids, The patient is
Hmm.
now being planned for immunosuppression.
Okay. So ideally, if it is an active vasculitis, the thing is first you do the workup, try to find out the cause. And if cause is found out, you have to treat that one along with you have to give systemic steroids. And during the follow-up in the active phase, you have to very carefully monitor the retina to see whether any new vessels are happening in the periphery. Okay. So that we can do. Or else once you feel like, okay, the vasculitis is completely resolved, you can plan for an FFA to find out the peripheral CNP areas. And this CNP areas, you can do the laser. And very rarely, in the initial presentation itself, some patients will have vitreous hemorrhage. These things usually happen in case of Eales disease or tuberculosis or sarcoidosis, where a low-grade vasculitis can be there for a long time, which has created this peripheral new vessels and vitreous hemorrhage. So, if a patient presents to you with vasculitis and with vitreous hemorrhage, first sitting itself, you can ask for a FFA. If it is a very active vasculitis, first you find out the systemic cause, treat it with a careful follow-up, then you can do the FFA. But if you have doubt regarding retinitis or any other cause, obviously you can do early. Then what is the follow-up for this patient?
We can look for CNP areas and neovascularization in further follow-up. And then we can go for a laser photocoagulation in CNP areas. And then we can consider giving immunosuppression.
Yeah. So one thing you have to remember is whenever you give lasers, it will be better if you do it after little bit vasculitis has come down, unless it is already an NVE. Okay, at that time also, at least you give some doses of systemic, you do the lasers. Okay, sir.
Regina, when she listed the investigations, the investigations for autoimmune vasculitis, was the list complete? I thought I didn't hear. Anu, in your investigations list, no, all the routine investigations for autoimmune vasculitis, you had enlisted, is it?
Sir, ANA, RF factor, PNK and PNK.
Okay, they were done. They are done. Was with the normal limits.
It was with the normal
limits. And the other thing, all these cases of, so we have got a problem with the vessel. We do not know if there is any problem with the contents of the vessel. The hemorrheological, because it's ideal that you do a peripheral smear also.
Yeah.
So I think you didn't mention that. And another thing, probably young man, bilateral involvement. The other eye also he had findings, no?
Yes, sir.
Starting steroids is easy, but I think the other rarer causes of infectious vasculitis, no. I think essentially our other than the routine investigations, among the infective vasculitis, I think we were looking for only tuberculous etiology, no. So infectious vasculitis also, no, probably young man with extensive involvement in the posterior pole. So the other causes of infectious vasculitis also probably, it better be ruled out. Rarer causes of infectious vasculitis. Regina, it was a good discussion. I think all the things were. Anu, will you go to your first slide? First slide. And before that? Before that? So you have told 4 points, no? Okay. Then come to the summary slide.
That is 22-year-old in that summary.
So the problem is though between 22 and 24, and nothing significant is there, no. And this will tell you that you are not very keen or not. It will can be considered as a point of disinterest, no. So so the first slide, last slide. So though whether this 2-year difference makes a problem in the diagnosis is not there, but anyway, no. When you present for the exam or whenever we present, no, there's small things. Sometimes people don't. Right. Smita, JP.
I think, sir, that was a very nice points. You have made very nice points, sir. I really appreciate that. I just want to add to this what she has said. Even Regina, you have done a very good discussion. I find that very good discussion. When you say vasculitis, Anu, you have to impress people why you consider it as vasculitis. You mentioned that the patient is young. But what are the other points? The bilaterality which sir pointed out is very important. Then there were those multiple patches or multiple areas of vasculitis along that vessel, along the branches of the vessel that you are seeing. There's not a single area of vasculitis. You were seeing periphlebitis along different segments of the vessel, of that vessel, and in the other eye. So that has to be appreciated because in your differential diagnosis, even though you have written it, you have not mentioned it, I think, about branch vein occlusion in the young person or venous occlusion in the young person. You did not mention that. So your vasculitis, you should impress or tell people why you consider vasculitis by telling that this is in a young person. There are multiple areas of vasculitis. There are bilateral, and there is occlusion away from the AV crossing. It's not, even again in your fundus diagram, it seems very near to the disc, but in your fluorescein angiogram, it seems after the second AV crossing. Am I right? So you should say that this is peripheral. I'm going to describe it so that people understand that this is vasculitis. Your fundus picture could mean a venous occlusion. Okay.
JP, any other faculty from other institutions to comment? നിർത്താം Regina.
Okay, sir.
So Elizabeth.
Okay. Thank you, Dr. Anu, for your presentation. Thank you, VS sir. Thank you, Smita ma'am. And thank you, Regina, for your wonderful discussion. And so we can conclude our discussion today. And we will meet for the next case presentation next month, probably the first week of March. Thank you. Good night, all.